So here we'll walk through a primer on peripheral nerve innervation and neuroanatomy. We'll be focusing on upper limb and lower limb innervation, normal anatomy, and then also mononeuropathies and plexopathies. On the site, there's an extensive muscle nerve directory that goes through muscle groupings and their actions. We'll sort of stay away from that end of the spectrum and focus more on just innervation patterns in this session. So this is the brachial plexus. It's core to understanding peripheral nerve innervation. Its major organization is rami or roots, trunks, divisions, cords, and then terminal nerves. The key roots, C5 to T1. There's also this notion of a prefixed plexus and a postfixed plexus with some innervation of surrounding roots, but those are the core roots. C5 and C6 form the upper trunk, which then forms the lateral cord. C8 and T1 form the lower trunk, which then forms the medial cord. And then C7 forms the middle trunk here, and then the posterior cord is formed from posterior divisions of the upper, middle, and lower trunks. So here are the divisions themselves. There's the posterior divisions of all these trunks that make up the posterior cord, and then the anterior divisions make up the lateral cord and the medial cord. The terminal nerves, core to understanding any sort of nerve innervation of the limb here. Ulnar nerve comes off of the medial cord, and then the median nerve is a combination of both the lateral and medial cords, and then the radial nerve comes off the posterior cord. As a general rule, the innervation pattern is such that with the radial nerve, there's wrist extension. So you think about the posterior surface of the arm and extension. With the ulnar nerve, it's medial flexion, so flexion with medial directionality. And then with the median nerve, it's flexion with lateral directionality. And remember, in anatomic position, this is medial and this is lateral. So, some additional nerve branches. There are quite a few coming off the brachial plexus. We won't go into them exhaustively here, but the musculocutaneous nerve, core with biceps innervation. And then the medial brachiocutaneous and medial antebrachiocutaneous are important because they're pure sensory. The medial antebrachiocutaneous is forearm, and then medial brachiocutaneous is upper arm, and they can help differentiate injuries at various sites along the plexus here. In terms of some key plexopathies, upper trunk, Erb's palsy, Wader's tip palsy, lower trunk, Klumpke's palsy, claw hand. We'll talk about this a little bit more in a second. And then with the long thoracic nerve, we can get scapular winging. So this is the brachial plexus within its anatomy itself. So here are the roots, C5 to T1. This is the axillary artery. These cords are named based off their relationship to the axillary artery. So the posterior cord lies posterior to the axillary artery here, and then the medial cord is medial and lateral is lateral. Here's the radial nerve. It's passing posterior along here along the humerus, and then here's the median nerve and then the ulnar nerve here. And then some key, additional key anatomy here. Thoracic outlet syndrome, compression of the lower trunk here, and then scapular winging like we talked about with long thoracic nerve injury. There can be winging of the scapula. And then we just point out as well the axillary artery here and musculocutaneous nerve here. So here are core innervation patterns. So musculocutaneous nerve, C5, C6, biceps brachii, axillary artery, C5, C6, deltoid. Note that the musculocutaneous nerve comes off the lateral cord, whereas the axillary nerve comes off the posterior cord. So although the deltoid and the biceps both have C5, C6 innervation, they're innervated from different cords. And so this is the type of reasoning that you need to be able to do to differentiate whether something's coming from a muscle, terminal nerve, cord, or trunk based on all of this patterning. And it just takes time and repetition to get it down. Upper limb plexopathies. We talked about Erb's palsy, upper trunk, birth trauma is a common etiology, or from breaking a fall. And then the deficit is a waiter's tip palsy, and there's a pictorial on the site where you can see what that looks like. Klumpke's palsy, lower trunk, similar etiologies. Claw hand is what the manifestation can look like. Thoracic outlet syndrome, again lower trunk. Cervical rib or Pancoast tumor, key etiologies, and then is a claw hand with some vascular signs because there can be vascular compression here. And then as a mononeuropathy, we talked about scapular winging, long thoracic nerve, serratus anterior muscle, trauma, stretch, compression, can be idiopathic, and then there's prominence of the inframedial scapula on evaluation, and you have patients push against the wall and you can see the scapular winging. Upper limb nerve anatomy. So median, ulnar, radial. Very important to know cold here. So here's our limb. Here's some key anatomical features. The brachial artery here, the cubital tunnel here, Guyon's canal and the carpal tunnel here, and then here's our sensory map of the palm. So radial nerve comes down posteriorly. It only has this small sensory branch here in the hand, just this lateral aspect of the thumb here. And note that we're on the anterior surface. We'll go through the posterior surface in a second. So then the median nerve comes down along the brachial artery here. There's some potential compression points here in the forearm. And then very importantly, it goes through the carpal tunnel. So in carpal tunnel syndrome, there's irritation of the median nerve. So its sensory pattern here is what's going to be activated in carpal tunnel syndrome, and that's where the nerve irritation is going to happen. The ulnar nerve here, cubital tunnel is a key compression point, and then Guyon's canal is a key compression point. And again, there's all sorts of takeoffs of various nerve terminals here, or nerve branches here. And again, it's all about understanding the patterning in order to make a diagnosis of localization of where the site of injury is. On a posterior standpoint, here we see the radial nerve again. Now, as we can imagine, since it's posterior, we're going to see more sensory innervation on the back side of the hand, on the posterior surface of the hand, than we did on the anterior surface. Key differentiation here, this superficial branch versus this posterior interosseous nerve. And again, there's nerve innervation patterns that help us distinguish that. Dorsal ulnar cutaneous nerve here, median, the ulnar coming off here. And then the median nerve sensory innervation just wraps around to these posterior tips of the fingers here. Note that with the median nerve, it's the thumb side, it's the lateral side of the hand, and with the ulnar nerve, it's the medial, the inner portion of the hand. Upper limb mononeuropathies, median nerve, carpal tunnel we talked about was one key one. Pronator teres heads is another potential key one. Carpal tunnel far and away is incredibly common. These other ones less common but still important to know. Deficit, wasted thenar eminence right here, the APB. If that's wasted, it can be a very severe carpal tunnel. Ulnar nerve, Guyon's canal down here. There's some differentiating features in the sensory pattern that you can use. Cubital tunnel, very common, very important to know about, and then it can cause this clawing here. But this is the cubital tunnel and the carpal tunnel are key compression points here. Radial nerve, the spiral groove is a very important one to know about, but there are kind of more sites where the radial nerve can end up getting compressed. And then the deficit, though, really key to know, wrist drop. So patients have inability to extend their wrist, and that can actually cause additional functional problems. So if they're unable to extend their wrist, they may also have trouble activating musculature that's innervated by the median and ulnar nerves. This is a detailed tutorial that we have on the site that goes through all of these different innervations in a sort of a nice laid out map, but you can see all of the different muscle groupings coming off in their various branch points. Again, EMG lab is a great place to learn this information. Lumbosacral plexus, so here's our anatomy over here. And then we're going to go through the hip and plexus innervation, and we'll take notes over here. So ilioinguinal nerve coming down and iliohypogastric nerve, L1. Note that the roots that comprise the lumbosacral plexus are much more broad, they're much more numerous than with the brachial plexus, L1 all the way to S5. It's less interwoven, however, so with the brachial plexus we went through all that spider web interweaving nature, less interwoven with the lumbosacral plexus, but more numerous roots to account for. Femoral nerve comes down, anterior thigh here. So L2 to L4, hip flexion. Here's the compartment over here, anterior compartment. So knee extension, really key for the quadriceps, and then hip flexion, climbing upstairs, rising from a low chair, and then also this checking of the bottom of the shoe. Obturator nerve comes in. This is the medial compartment, again L2 to L4, but here you're dealing with hip adduction, bringing towards midline, so helpful for gait and stability. And then on the posterior compartment, L4 to S3, this is sciatic here, and there's multiple different branches here, but superior gluteal hip abduction, inferior gluteal hip extension, and then the short rotators of the hip, as well as posterior cutaneous nerve of the thigh. There's multiple different cutaneous nerves of the thigh. Lateral femoral cutaneous nerve is the outer aspect of the thigh, and then posterior cutaneous nerve for sciatic on the back side of the thigh, and then pudendal nerve, very important, S4, S2, S3 in the pelvic region here, and we can see it down in here. Perineal and tibial nerves, so these are branches of the sciatic nerve once you get distal to the knee. So the common perineal nerve branches into a deep perineal nerve and a superficial perineal nerve. The deep perineal nerve, think anterior leg, tibialis anterior. The superficial perineal nerve, think lateral leg, peroneus longus and brevis. And for the tibial nerve, think posterior leg, gastrocnemius and soleus superficially. From a deep standpoint, tibialis posterior, and then the plantar foot, the intrinsic foot muscles. So we're going to go through these nerves and then some key compression sites. So from an anterior aspect of the leg here, here's the sciatic nerve coming down. Now, obviously it's a posterior directed nerve, so we're going to see it go along the backside here, and then the common perineal nerve wraps out, splits at the fibular neck, very key compression point. Deep perineal nerve comes down anteriorly here, innervates tibialis anterior for dorsiflexion of the foot, and then has a superficial branch that innervates lateral musculature, so peroneus longus and brevis out there. And then when it comes to the tibial nerve, it's going to remain posterior, so we don't really account for it much on the anterior aspect of the leg here. So like we said, perineal nerve, key compression site, fibular neck. From the posterior aspect of the lower extremity here, here's our sciatic nerve coming down. We already established what our perineal nerve's doing, but it's going to be in the anterior aspect of the lower extremity. The tibial nerve comes down here, tarsal tunnel. This is a key potential compression point for the tibial nerve. And you can see some of these sensory and motor branches distal to the tarsal tunnel. And then the sural nerve, this is an important sensory nerve. It takes innervation from both the perineal and tibial nerves, and we use this in EMG, nerve conduction studies, to assess sensation in the lower extremity. It's very distal, and it's affected pretty early in peripheral neuropathies, such as diabetic polyneuropathy. So lateral malleolus is a key compression point for the sural nerve, and then for the tibial nerve, like we talked about, the tarsal tunnel down here. We hadn't mentioned it, but the popliteal fossa is also an important potential compression site for the tibial nerve. Dermatomes. Last thing we'll go through here, sensory patterning innervation of the skin. These are really key for clinical practice because they relate to muscle stretch reflexes and are really important for localization. So C2, back of the head, and then the jawline. So we'll go through things posteriorly here and anteriorly here. Here's C2, back of the head, C3, C4, the neck, both anteriorly and posteriorly. C6, think about, and we try to just point out some just simple landmarks. Although these dermatomes stretch over long areas, if you know some simple landmarks, you'll have some orientation points. So C6, think thumb. C7, think middle finger. C8, think little finger. So C5 is the upper arm. C6 is the forearm, and then on the lateral aspect, and then on the medial aspect, T2 is the upper arm, and T1 is the forearm on the medial aspect, and then C8 kind of extends down here to cover the little finger. And you'll notice that things are very similar on the anterior as they are on the posterior. So you can use, so if you know one, you'll be able to intuit the other. T4, nipple line, important site. T10, umbilicus, important site, especially in spinal cord injuries. For localization, it's helpful to know about the nipple line and the umbilicus as a way to localize at a thoracic level where the injury is. And then in the leg, there's this sort of wraparound that you see. So L2 across the upper anterior thigh, L4 comes across the patella. That's really helpful to know. And then L5, great toe, S1, little toe. We can see that both anteriorly and posteriorly. Finally, we talked about the pudendal nerve, S2, S3, innervation, and the genitalia, and then the coccyx at the anus here. So that's a whirlwind of peripheral innervation. Don't forget to look at the muscle nerve directory on the site because it goes through all of different muscle groupings and their actions in a very memorable way.